This investigation was on controversies in MDS classification systems, carried out by Dr. Adela Perolla, from University of Medicine, Department of Internal Medicine, Service of Hematology, Tirana, Albania.
And now I will present you my speech on this conference about the controversies in myelodysplastic classification system that is used nowadays. So a little short introduction to myelodysplastic syndromes. There are a heterogeneous group of clonal origin, so it's a cancer, characterized by different degrees of mismatch between the proliferation and the differentiation capacity of the hematopoietic stem cell from which derive all our blood cells. And normally it's expressed in an progressive cytopenia with anemia, platelets, low platelets, and low white blood cells. But also we have qualitative alterations of these three hematopoietic series, and we present here a group with a high risk of transformation in acute leukemia, acute myeloblastic leukemia. So facing this heterogeneous group with the incidence of 3 to 4 individuals for 100,000 per population, the prevalence it's increased with the age, and the 75 years it's the average age of diagnostication. So in the age above 60, the prevalence is higher than less than 60 years old. Affects more the males compared to females, and also exposure to the prior chemo or radiotherapy. It's a risk for the development of myelodysplastic syndromes. So there are 4 points to have to keep in mind. There is a distorted hematopoietic stem cell function. We have a deregulation of the inflammatory and innate immune system, and we have an apoptosis deregulated, and we have a lot of genomic events that can help arise giving the origin of myelodysplastic syndromes. Those are the results, what is expected to be the myelodysplastic syndromes in the future. So we have until 2034 an increase of the myelodysplastic cases in the future. And the most important thing is that even if it's an elderly disease, approximately 5 children are diagnosed per year with this disease. So it's really, really important to keep in mind this disease and these incidences. The most important key point is the evolution of the diagnostic tools. In fact, it was first diagnosed from Di Guglielmo, who first described morbo Di Guglielmo, all the anemias who didn't respond to iron and B12 and acid folic treatments. And after that, it was called with the term of pre-leukemia anemia, because it was seen that a lot of patients with those changes transformed in acute leukemias. And after that, in 1963, it was classified as smoldering acute leukemia, going with the French-American British classification. It was the first used based on the morphological characteristics of the cells, and it was the FAB classification that sometime in the low middle income countries it's still used. But after that, WHO has evolved with other elements in this classification, including here also the karyotype and the genetics, and making a little bit more specified and more complicated the criteria to diagnose myelodysplastic syndromes. But it's still evolving. Actually, in 2024, we have the 2 classification. This one in the left side of the screen is the ICC 2024 classification, and in the other side of the screen, we have the WHO classification of 2024. And there are some discrepancies between them, but the most important thing is that they have classified myelodysplastic syndromes mostly based with genetic anomalies. They are found in the karyotype, in the next generation sequencing, but the most important thing that never change on diagnosing these diseases, they are the morphological founds. The classification of myelodysplastic syndromes, it's a subject of debate, and there are more than three areas of this controversy debate of classification. The first debate is the morphological criteria, because the WHO classification relies heavily in the morphological evaluation of bone marrow dysplasia, but this can be subjective because it depends on the pathologist that is behind the microscope and that can evaluate the morphological structure of the cells they are seeing. So we have an inter-observer variability, but to regulate this, there are some minimal diagnostic criteria for myelodysplastic syndromes, and there are the prerequisite criteria that are the constant cytopenia of one or more cell lineage. For example, we must have the hemoglobin less than 11 grams per deciliter. We must have absolute neutrophil count less than 1,050 per microliter, and also low megakaryocytic or platelets. Important what we have to keep in mind with these minor criteria that can be used in low middle income countries that have struggles or difficulties. So with the other measures that are evolving, like in next generation sequencing, etc., in this kind of diagnostic field, we have the MDS decisive criteria that the dysplasia seen must be at least 10% of all the cells, and also must have 5 to 90% blood cells or immature cells in the bone marrow, and also we have to use karyotyping or FISH. The second hot point of debate, it will be the use of genetic and molecular factors, because there are a lot of mutations that if found in the blood, in the bone marrow of this patient, could be like the diagnosis. Even if we find or not the morphological changes in the bone marrow. And for example, in the ESPO 2021 guidelines recommend that we have to maintain the analysis, the molecular analysis, to see also the prognostic value, especially for the mutation of TP53, and also in the patients that have the deletion of the long arm of chromosome 5. And also we have to check about the SF3B1 mutation in all the patients with myelodysplastic syndromes with less than 5% of blasts, classifying them like high risk or high intermediate risk. And the third hot point of debate, it's what kind of prognostic score system we have to use. There are a lot. We have the international prognostic score system, but we have also the revised version. And I have demonstrated here the two categories, and the applicability of those scoring system across different populations. Sometimes it's not all 100% possible. So this would be a point of debate, because diagnosing those patients in the population that are not able to perform all the points of these prognostic scoring systems, what could be? So what would be the best with the minimal requisites scorings for making the prognosis of myelodysplastic diseases. And also we have another, it will be therapy-related MDS. Ultimately, the therapy-related MDS has been included in the current WHO classification in the group with therapy-related acute myeloid leukemia. We know that myelodysplasia, it's a different subtype of diagnosis, but here in this classification, in WHO, it's put together with the acute leukemia. Even we have morphologic and different morphologic and prognostic features. So those are the classification, or the 5th edition of WHO classification of myelodysplastic syndromes, still remaining with the morphological, including all the point of debates that I have already said. But most of all, the most important thing, we start from the single or multilineage dysplasia, following up until to performing the TP53 biallelic mutation. And this is a pyramid we have to follow to make the diagnosis with the 5th current edition of WHO for the diagnosis of myelodysplastic syndromes. So here are the countries' income levels in 2024-2025, and we see that the situation we have with blue, the high income, upper middle with the orange color, and we have also low income in Africa and some places. So we have to keep in mind that in those places that are in low income, not classified, or lower middle income, we have to find the minimal requisite criteria to diagnose myelodysplastic syndromes, because if we are applying the last recommendations in those countries, it's impossible to perform some levels of genetic analysis, and this makes a little difficult the diagnosis of myelodysplastic syndromes, or we can have overdiagnosis or we can have underdiagnosis. So in conclusion, controversies normally are generated from the continuous evolution of the classification criteria, and also we have an overlap between MDS and acute leukemias, and normally it's important to keep in mind the applicability of these systems across different regions worldwide. And while the WHO has evolved and had improved the prognostic accuracy, we remain with those problematics, especially for diagnosing the secondary MDSs in low middle income countries. But we have to keep in mind also that the future classifications have to integrate all the risk factors and to consider also the regional differences to provide the most accurate and effective clinical management of this patient. So this is my reference. This was my speech. Thank you for the attention.